Hello everyone, in this video I am going to discuss about HbA1c. So HbA1c stands for glycosylated hemoglobin or glycated hemoglobin. What do you think? Let us understand. Let me discuss the basic things first. HbA1c. In HbA1c, HbA stands for adult hemoglobin. Adult hemoglobin contains 2 alpha and 2 beta chains. Here you can see a 3D structure of hemoglobin A, that is adult hemoglobin. One in dark blue and dark green are alpha 1 and alpha 2 chains of adult hemoglobin. One in light green and light blue are beta 1 and beta 2 chains of adult hemoglobin. In the center you can see 2,3 bisphosphoglycerate molecule, and these 4 red colored structures are heme moieties. Now let us understand what this 1C means. Here you can see hemoglobin electrophoresis image. It contains major and minor peaks. Major peak has been designated as HbA0 and it is due to deglycated hemoglobin. Minor peaks are multiple and designated as HbA1. HbA1 has been subdivided into 1A to 1E on their chromatographic elution order. These minor peaks are due to binding of various adduct to HbA. Glucose was unequivocally identified to generate most abundant HbA1 fraction, that is 1C. Hence 1C has been used as a part of the term HbA1c. So HbA stands for adult hemoglobin, 1C means minor peak in the Hb electrophoresis because of glucose. Hope you understood. Now let us understand the process of glycation. Glucose, when enters erythrocyte, can form a covalent adduct with the epsilon amino group of lysyl residue and N-terminal valine of hemoglobin beta chain together to form a structure termed as HbA1c, and the process is called as glycation. It is a non-enzymatic process. Glucose with hemoglobin together initially form Skiff base and then Amadori product called as hemoglobin A1c. Here you can see a model depicting normal hemoglobin and HbA1c product, where blue colored structures are glucose attached to hemoglobin. Now let us also understand the process of glycosylation. It is a ubiquitous modification of newly synthesized protein in the endoplasmic reticulum dependent on the links of oligosaccharide to the amino acid side chain of the protein. We have two type of glycosylation. One is N-glycosylation, other one is O-glycosylation. This process is an enzyme mediated N-acetylglucosamine transferase and multiple isoenzymes of other glycosyl transferases are involved. Hence HbA1c is not glycosylated hemoglobin, it is glycated hemoglobin. The process of glycosylation and glycations are two different. Now A1c measures your average blood glucose for the past 2 to 3 months. Lifespan of RBC is approximately 120 days. T half of RBC is 60 days. So approximately we can measure average blood glucose of past 2 months using HbA1c, though clinically we say it as past 3 months. Normal HbA1c values are less than 5.7. When the value is between 5.7 to 6.4%, we term it as pre-diabetes or IGT, impaired glucose tolerance. When the value is 6.5% or higher, then we term it as diabetes mellitus. Coming to the limitations of HbA1c test, it is an indirect measure of average glycemia. So the better test is CGM, continuous glucose monitoring. Conditions like hemolytic anemia and other anemias, G6PD deficiency, recent blood transfusion, use of drugs that stimulate erythropoiesis, and end-stage kidney disease, pregnancy may result in discrepancies between A1c result and the patient's true mean glycemia. Hemoglobin variance is another confounding factor. Always use NGPS certified assays to measure A1C. Coming to recommendation, when to do this HbA1c. One, at the time of diagnosis. Second, at least 2 times in a year in patients who are meeting treatment goals and who are have stable glycemic control. Also, at least quarterly and as needed in patients whose therapy has been recently changed and who are not meeting glycemic goals. Coming to glycemic targets, in non-pregnant adult, try to keep HbA1c at less than 7%. HbA1c has to be individualized. In a diabetic whose risk of developing hypoglycemia is low, is newly diagnosed with long life expectancy, without any important comorbidities, and without established vascular complication, and patient prefers, try to keep HbA1c less than 6.5%. That is desirable. In a patient whose risk of developing hypoglycemia is high and with long-standing diabetes, with short life expectancy, and has associated multiple comorbidities and with established vascular complications, you can always keep HbA1c between 8 to 8.5% also. That is also acceptable in a less stringent side. So mean HbA1c is 7% in an adult non-pregnant. Hope you like this video.